Greetings everyone, and thank you for joining us today. I'm Cindy Salim, the Program Officer at KAS Rule of Law Program for Sub-Saharan Africa. During the next hour, we shall be discussing the impact of COVID-19 on the rule of law and human rights in Sub-Saharan Africa, and we shall focus on the right to health. This online seminar will seek to interrogate the present health systems, evaluate the existing challenges from the legal and policy frameworks, and consider emerging opportunities. In the foregoing, the online seminar shall be guided by the General Comment number 14 of the UN Committee on Economic, Social, and Cultural Rights, which provides detailed guidance to states regarding the obligations to respect, protect, and fulfill the right to health under the four interrelated and essential features, that is, availability, accessibility, acceptability, and quality. Our panelists during this session will be Ms. Speciosa Avako, who is a lawyer, legal researcher, and an advocate of the High Court of Uganda. She's currently a legal manager and senior legal associate at M. Kamanzi and Company Advocates located in Kampala. She has engaged extensively in human rights, litigation, and legal research to enable vulnerable people to access justice. She is passionate about the human rights, constitutionalism, and the rule of law. From Nigeria, we have Dr. Ibrahim Banaru, who is a human rights enthusiast and trainee family physician with Ahmadu Bello University Teaching Hospital, Zaria, Nigeria, where he works as a first contact care provider amid the ongoing COVID-19 pandemic. He has a specialist background in SRHR, earning an MPhil in sexual and reproductive rights with unyielding commitment to research and advocacy in health policy. Ibrahim has earned considerable experience in the development space through voluntary roles, including Youth Advisory Board of UNFPA Nigeria and One Campaigns International, where he has practiced and upskilled in conceptualizing and promoting innovative development strategies. He currently serves on the board of numerous organizations and thematic working groups, among others, the Health Thematic Working Group from the Nigeria National Development Plan post-2020. And with us is also Dr. Amanda Mugadza, a lecturer in the Public Law Department of the Faculty of Law at the Midlands State University in Gweru. Her areas of specialization are in environmental law, including sustainable development, natural resources law, the law relating to transportia, conservation areas, sustainable tourism development, climate change law, and related aspects of public international law. Her interest in human rights is drawn from her persuasions of the interrelationship between environmental rights and all other rights, as well as the understanding that environmental well-being influences on all human rights. We are also joined by my colleague, Peter Wendo, who will give us brief remarks before we delve into our discussion. Over to you, Peter.
Thank you, Cindy, for those remarks, and thank you to all the panelists and all those who are joining us for this webinar. I hope that in the next 1 hour or so, we'll have a fruitful discussion. And on behalf of the Konrad Adenauer Foundation, generally, I would like to appreciate your participation. And on behalf of our director, Dr. Anne Wolf, I also would like to welcome you on board and convey his apologies that he cannot join us for this webinar due to other commitments. As Cindy has said already, we are going to focus on the impact of COVID-19 on the right to health on the continent. And let me start by saying that the promotion of human rights is one of the main pillars of the work of the Konrad Adenauer Foundation. And for the Rule of Law program in particular that is convening this webinar, we have deliberately given prominence to the promotion and protection of social and economic rights on the continent since its inception in 2006. And this is premised on the programs and our belief that a healthy, nourished, knowledgeable, and empowered population is better placed to enjoy and demand for their fundamental rights that guarantee their livelihoods, dignity, and survival. And although the reported statistics show that the rate of infections and fatalities in Africa due to COVID-19 remains relatively low compared to the other parts of the world. These numbers are increasing every day, and the reality of this disease on the continent is very evident. So it is clear that COVID-19 pandemic has stretched even the most advanced health systems in the world. Yet prior to the pandemic, the medical and healthcare systems in Africa, and especially the public institutions, were already weak and struggling due to a number of reasons. One of them is lack of adequate medical and health facilities. When you look at the number of hospitals and health centers across the continent vis-a-vis the population, this number has always been greatly imbalanced. And where the hospitals exist, there has been a challenge of adequate and functional equipment, as well as adequate and safe medicines. Where there are hospitals and equipment, there is the challenge of adequate qualified personnel, with the continent's best opting to go and work abroad. And where there is, we've had situations where we have qualified personnel, then you realize that their welfare, their remuneration, and the general welfare of these personnel has not always been taken care of, and therefore affecting the quality of service that we get from our health institutions. So generally, we can say that the medical and health systems on the continent suffer lack of financial and research support that is needed to deal with both the existing diseases on the continent and as well as the new pandemic that has struck the world. For COVID-19, there are certain things that must be put in place. One of them is emergency services, the testing kits, the intensive care units, ventilators, the PPEs, all these things, we are still grappling with them, and that ultimately affects the quality of medical and health services that we get, and therefore negate our right to health. As we deal with this unknown and unseen enemy, which we don't know how long it's going to stay with us, I think it is time that we try to reflect on what we need to do as Africa, and what this whole situation portends for the continent insofar as the realization and enjoyment of the right to health in Africa is concerned. So during this pandemic and beyond the pandemic, I think some of the things that we need to deal with include how do we get the balance between the promise for progressive realization of the right to health vis-a-vis the rampant corruption and wastage of public finance that we continually see on the continent? How do we get the balance between the need for universal health care in the face of increased privatization and commercialization of medical services on the continent? How do we get the balance between improvement, retention, and safety of our medical personnel? And then how do we deal with the whole question and getting the right balance between daily hustle for water, food, housing, means of livelihoods for majority of the people on the continent versus the restricted movements, mandatory acquisition of PPEs, especially the masks, and the physical distancing as a means of controlling the widespread of the infection. COVID-19, medical aftercare, and the stigma that is associated with it. How do we deal with all these things? So for this and much more, I hand over to Cindy and the panel of panelists to try and take us through the discussion. And I hope that at the end of it all, we will then have something that we can work on beyond our screens and the buttons of our keyboards. Thank you, Cindy, and over to you now.
Thank you, Peter, for your remarks. Throughout global efforts to tackle COVID-19, it's been clear that health workers face the highest risk. They need personal protective equipment, PPE, welfare and job security to fully combat this health crisis. And these tools need to reach every one of them, everywhere equally. Health workers across sub-Saharan Africa have raised concerns, claiming that they do not have access to these basic things and their welfare is not well taken care of. Many governments have gone ahead to deny these claims. We've had reports in Nigeria, that is Abuja and Lagos, that hospitals have been closed because healthcare workers have fears over their own lives, and in some instances, they are turning away patients who are suffering from COVID-19, citing that they are afraid of interacting with patients with this disease. Though we know that such actions are unethical, the health workers have cited the risk involved in handling patients due to lack of PPE, and many staff have contracted the disease in the course of attending to the patients, among other reasons. The Nigerian government in May reported that more deaths were caused by failure of hospitals to attend to sick people rather than those caused by COVID-19. These cases are similar in majority of the countries in sub-Saharan Africa. So over to Dr. Banaro, who's a medical officer. Kindly tell us the current situation of health workers, the health workers are facing in sub-Saharan Africa, and are there any measures that have been taken by the government so far to ensure that health workers are being protected as they continue to execute their duties?
Thank you very much. Good morning, everyone. Good morning from Nigeria. Thank you for having me. As everyone is aware, COVID-19 pandemic is an unprecedented public health crisis in living memory. In the recent past, we cannot recall in public health, we cannot recall any public health crisis that has really put the whole health system in extreme pressure like COVID-19. As health workers, we know beyond the human nature, it is a professional calling for health workers to extend hands of help to patients and the general population. The health workers have consecrated their lives to the service of humanity. But COVID-19 is rapidly increasing and putting the health system under extreme pressure. You will agree with me that when you are flight bound, the flight safety instructor would say, put on your mask before helping others. This in-flight safety metaphor simply puts is that you cannot help anyone else when you are helpless or dead. So this is exactly the trouble with health workers in sub-Saharan Africa. You do not have the protective equipment to protect yourself before you can extend these hands of help to others. That is exactly what is happening in sub-Saharan Africa. Health workers are in dire need of protective equipment to really extend protection to the community. We understand that the government has put in place some measures across sub-Saharan Africa, looking at Nigeria, Ghana, the Gambia, to protect health workers. Some of these measures that I can highlight are prioritizing screening and testing for health workers. Studies have shown that if health workers that develop symptoms are isolated, it reduces the risk of infection to about 25%. So some hospitals have put in place measures to isolate health workers that have already developed symptoms, not necessarily have come down with the disease, but have developed symptoms that make them suspected cases. If those health workers are isolated, it reduces the risk of infection. However, because of the paucity of hands in the health services, as you're aware, the World Health Organization advocates for one health worker, one doctor to about 600 clients and about 41 health workers to 10,000 population. This is grossly, which is grossly not the case in sub-Saharan Africa. So due to the paucity of hands in the health system, doctors are not allowed to go on isolation as the case may be, or as time as at when due, and this increases the risk of infection among healthcare workers. Provision of adequate protective equipment, the PPEs. We acknowledge that there is a global shortage of personal protective equipment, but governments have put in effort to procure this equipment and then put in local content measures to produce the personal protective equipment. I can say in Nigeria, for instance, the availability of PPE is still grossly inadequate. there's this issue that is currently ongoing. There are debates about who is the frontline healthcare worker. Some people may define frontline healthcare worker as the healthcare worker that is at the designated COVID-19 isolation and treatment centers. Whereas in the real sense of it, a frontline health worker is any health worker that is currently working. What I mean, any health worker that is currently working is a frontline healthcare worker, because any client that comes into the clinic might be a potential case of COVID-19. Therefore, every healthcare worker, the one that is at the community, serving communities, serving underserved communities, is also a frontline healthcare worker who requires full personal protective equipment. There are levels of this personal protective equipment. Those that are treating confirmed cases have the level A protective equipment, and thus others have other levels of protection. So the basic minimum for protection, which includes the medical mask, gloves, and goggles, should be provided to every health worker, including those at the community. So this is inadequate, as we have seen health workers going on industrial action to protest lack of this equipment. Recently, just a few weeks ago, the Nigeria Association of Resident Doctors went on a national strike protesting the inadequacy of personal protective equipment, citing a number of health workers, including doctors, who have contracted COVID-19 and some who have succumbed to the disease. And to really protect the community, the government needs to understand that no health worker should come down in the line of duty in order to protect the community. Because as we know, the World Health Organization advocates for 1 doctor to 600 population, which is grossly not available here in Nigeria and other sub-Saharan African countries. We can understand that if one health worker goes into isolation, then definitely the whole system is depleted, and then the services that are provided in other aspects of the health system suffers. For instance, if a health worker that is at the obstetrics and gynecology unit is isolated, it means a number of pregnant women who would access antenatal care services easily would find it difficult to get that services, which means while COVID-19 is ravaging, other health services and health indices would also be touched. So as we are grappling to reduce the incidence of maternal mortality ratio, we may at a point then lose this achievement, the little achievement that has been made due to health workers succumbing to COVID-19, getting into quarantine isolation, and some even dying from the disease. Another issue that is of concern is setting up of disinfection procedures. At the level of the healthcare facilities, disinfection procedures, water, sanitation, hygiene systems within the hospitals are inadequate. You can see hospitals, even at the tertiary levels, without running water at the facility, at the clinics, and the wards, which portends danger to healthcare workers who are treating patients with COVID-19 and those who are first contact care providers who see patients, triage them, and isolate, as the case may be, point out that this particular client is a suspected case and should go to the isolation for testing. So lack of those disinfection procedures and facilities also increases the risk of infection among healthcare providers. So there is a need for health facilities to put in place measures, including running water, disinfectants like hand sanitizers, and ultraviolet lights, which are used to disinfect when confirmed cases are taken care of in a particular location within the hospital. This will reduce the risk of infection to healthcare workers. Another issue of concern, which I've earlier highlighted, the inadequacy of staff members in the healthcare system. One issue that really bothers health workers currently is the mental health support services, which is close to none. I cannot recall any of the governments really putting in place clear measures for mental health support services for healthcare workers. As you would understand, governments in Nigeria, Ghana, and other sub-Saharan African countries have put in place, have designated isolation centers that cater for confirmed cases of COVID-19. The designation of these centers means healthcare workers who were primarily in other posts were now drafted to these isolation centers, which means they now work longer hours than usual. They now work in situations that they've never practiced in the past. Like I earlier mentioned in my opening statement, that COVID-19 pandemic is an unprecedented public health crisis in living memory. So these healthcare workers are working in a situation that they've never seen before. And they have concern about mental health issues and exhaustion and burnout. There are no particular measures that are specific for mental health support to healthcare workers that we see in most countries in sub-Saharan Africa, especially by the government. We are seeing some civil society organizations, non-governmental organizations, coming to give support, mental health support to the general population. But that of health workers is quite peculiar, and it needs the government to really put in place distress helplines where health workers can really report burnout. They can really report any mental health issues such as depression and burnout to appropriate authorities so that they can be taken care of. You would understand why health workers may fall into depression in this condition. Some of these health workers that are working in the isolation centers work on routine shifts of a week or 2 weeks, and then they take 2 weeks off. So you will see that in the whole 1 month, a healthcare worker may not be able to see his family, because when you work those 2 weeks at the isolation center, you're supposed to go on self-quarantine for another 2 weeks, so that you're sure you do not you've not contracted the COVID-19 and you do not develop symptoms before you can be able to see your families. So health workers are away from their families for quite long, and they are working in conditions that are unprecedented. This really portends danger to their mental health status, and there are no peculiar measures to really help health workers in that regard. Before I come to a conclusion, there's need for recruitment drives to really augment the number of health workers that are currently in the front lines and working in other non-COVID designated centers. I mentioned that there is gross paucity of healthcare workers across sub-Saharan Africa. Therefore, governments need to put in place a recruitment drive that will see healthcare workers that are not in the government employ or in the private sector are pushed up and trained to really work in this sector to augment the current number of healthcare workers that are in the front lines. That means we can be able to have adequate substitute for those who go into isolation, so that we do not put the limited number in a long duration of hours of service and cause unnecessary burnout. This and then another measure that well, some governments in Nigeria particularly, and then in Ghana also it has been put in place, is provision of motivation, financial motivation to healthcare workers. There were provisions of inducement to health workers in Nigeria. The Nigerian government gave 50% of the basic salaries of healthcare workers to them as upfront inducement to motivate them to continue to work during this pandemic. However, it took long. It took long before, after the pronouncement of the President of the Federal Republic, before these incentives were given to the health workers. In fact, it was one of the key points of the Nigeria Association of Resident Doctors that went on strike. They pointed out to the government that the president made pronouncement that healthcare workers will be given inducement to continue to work during the pandemic. However, it was not paid. Even as of this moment, some of the health workers are yet to get those inducement packages. And also the issue of life assurances, and then compensation in terms of illness. The government made a pronouncement that 5,000 health workers would be included in an automatic life health insurance and life assurance, rather, not health insurance, life assurance, and then compensation in the event of any health injury during the pandemic. However, healthcare workers are yet to see the implementation of this inducement. And then other sub-Saharan African countries are also making pronouncement, but the pronouncement may not be enough. It is the implementation that is the problem, which healthcare workers are currently facing. You will agree with me that for the community to be protected, for the community to be protected and reassured that we can really fight COVID-19, healthcare workers are the #1 resource in the whole health system that should be adequately taken care of to ensure that healthcare workers are able to be resilient, are able to be motivated to fight this pandemic. We all hear people talking about health workers as essential health workers, essential workers. They are essential, but they are undervalued. So we need to value health workers as essential workers. Thank you.
Thank you very much, Dr. Ibrahim. And as we have had, due to lack of resources, governments have started using tactics like trying to define who's a frontline worker in order, and therefore who will need PPEs. And in line with this, we know that progressive realization reminds us of the limits on resources. The COVID-19 pandemic has exposed gaps in health services that require urgent attention in many African countries. Health officials have said that inadequacies in resources are due to insufficient government investment in health, which in turn affects the ability of health workers to fulfill their duties, especially during this pandemic. Chronic lack of investment in healthcare infrastructure and equipment has made it harder for African nations to retain skilled healthcare workers, provide essential medicine, and reduce the mortality rates of perennial diseases which have affected Africans before, like malaria. So Dr. Amanda, kindly take us through steps that have been taken by the government of Zimbabwe and South Africa to ensure that they are making steps toward progressive realization towards the right to health.
Thank you much, Cindy, for this opportunity, and good morning, everybody. With respect to the right to health for South Africa and Zimbabwe, I could say all the legal mechanisms, at least the basic legal mechanisms, are in place. South Africa and Zimbabwe have both ratified international obligations with respect to the international covenants on human rights. The ICESCR has been ratified by both Zimbabwe and South Africa. Interestingly, South Africa signed to the ICESCR in 1994, but only ratified in 2015, while Zimbabwe ratified in 1991. Both of them are also parties to other international human rights instruments such as CEDAW, CRC, as well as regional instruments, the African Charter on Human and People's Rights. So at that level, there is legal efforts towards protection of the right to health. That has been translated into constitutional provisions. Both countries have provided for the right to health in their constitutions. In Zimbabwe, the right is provided for in Section 76, which provides that every citizen and permanent resident of Zimbabwe has a right to access basic health, healthcare services, including reproductive healthcare services. Then it also goes on to offer a right, or to provide for a right for every person living with chronic illnesses to have access to basic healthcare services. For that particular illness. And it also then provides something which is key for our COVID response, is the right that no person may be refused emergency medical treatment in any healthcare institution. Also very relevant then becomes the provision that says that states must take reasonable legislative and other measures within the limits of the resources available to it to achieve progressive realization of all socioeconomic rights, but particularly this right to health. Similar provisions, not exactly the same, but similar, are found in the South African Constitution. Section 27 provides that everyone has a right to have access to healthcare services, including reproductive healthcare services, and no one may be refused emergency medical treatment. Then it also similarly provides for the proviso for progressive realization of the right to health. Both countries have also gone on to promulgate legislation for public health. Zimbabwe has the Public Health Act. It's a very comprehensive one. South Africa has the National Health Act, which has been amended. It's a 2013 legislation. And both, in terms of these laws, both countries provide quite extensively for public health, but they also make provision for private health care. Both countries, as of course in the rest of sub-Saharan Africa, there's private healthcare, but it's only available to a limited few because private healthcare, as you would know, is quite expensive. So the majority of the people in both countries make use of public healthcare. So there are also policy instruments that are in place in both countries. But let me just say that, interestingly, the health budgets are quite, there are quite some interesting disparities there. Both countries have also subscribed to the Abuja Declaration of striving towards having 50% of their budgets dedicated to healthcare. While South Africa is almost there, it's about 13% has dedicated about 13% of its budget to health. And it's if you also consider all the efforts, it has a program which is called the social, which focuses on social sector development, and that social sector development program combined with healthcare could actually mean that South Africa surpasses or meets the 15% budget. The budget towards health, as well as its social development, which includes education and other social spending, is about or kind of meets and perhaps a little bit surpasses the 15% budget target of the Abuja Declaration. It has done much to do that. However, Zimbabwe is not faring very well. Over the years, the budget towards health has not been very encouraging. In 2019, it was at 7%, which is about 8% beneath the Abuja Declaration target. But interestingly, in 2020, we have moved up to 10%. We have dedicated 10% of our health budget to healthcare. So there is some efforts towards that at the moment. And however, you know, there's a lot that's been happening, as many of you would know, in our economy, a political economic climate, and our health system is almost collapsing, if I would say it like that. And therefore, the efforts towards budget here in Zimbabwe, I mean, the budget itself, as compared to what needs to be done in our health system, makes it seem as if, you know, literally nothing is happening. Then there's also discrepancies in the budget execution. It's quite weak. What is budgeted for, and then what actually then gets into putting effort in the health system is not at par. There's some diversions that have been reported that the budget, the monies allocated to healthcare are diverted in many ways, and that's the challenges that we have. South Africa, on the other hand, has done significantly much, I would say, although because the majority of the people are in rural areas and informal settlements, you know, the other determinants such as access to water and sanitation services, poverty, unemployment, etc., also then make it seem as though not much is being done in the health sector. But legislative-wise, I would say that efforts have been made to progressive realization. So responding to the COVID within this context, in Zimbabwe, our president declared the COVID situation a disaster, a natural disaster, and so we have had statutory instruments or legislative instruments that have been declared or that have been promulgated to respond to COVID, most of which have to do with mitigating mitigating on COVID, the spread of COVID-19, and rather than actually feeding into the health system itself. So, for instance, the instruments are working on curfews, as well as the putting on of protective clothing, for instance, masks, and there's been a lot of security forces have been put in the roads to put in curfews, roadblocks, to enforce the wearing of masks, to enforce curfews. But the same cannot be said about the provision of the adequate infrastructure and services within the health system itself. South Africa, on the other hand, which has also declared the COVID-19 a state of national disaster, has also enforced lockdowns and curfews, etc., but it has also then, because of the structure of the health system, which filters from the national health department to provincial health departments, that has helped provinces to address their localized COVID responses. And that in itself, that decentralization has helped South Africa respond more effectively to localized issues, as opposed to the Zimbabwean setting where it's all centralized. So these are the current issues with respect to the right to health that I would say to begin with we're faced here in Southern Africa. Thank you.
Thank you, Dr. Amanda, for that presentation. So we'll move over to Ms. Peciosa. And in light of the COVID-19 pandemic, it's having potentially catastrophic secondary impacts on the health of women and girls around the world. Decisions made at every level of the response to the pandemic are resulting in women being further cut off from sexual and reproductive health services, threatening sharp rises in maternal and neonatal mortality. Reports from Uganda indicate that already the combined ban that was there on public and private transport and a scarcity of public ambulances has cost the lives of women in labor. The International Planned Parenthood Federation, IPPF, announced the closure of more than 5,000 of its member association SRH clinics and care centers across the world. While others scaled down their services, Uganda is one of the countries that reported the closure of over 100 of these clinics. This is expected to impact the lives of many. In a statement, IPPF warned up to 9.5 million girls and women risk losing access to contraception and safe abortion services in 2020. Give us a brief situation on what is happening in Uganda and the measures that have been taken to ensure that the sexual reproductive health rights of women and girls are not forgotten during this pandemic.
Thank you, Cindy. Good afternoon from Uganda. Well, in Uganda, we first saw the president coming to declare a national lockdown starting from the 18th and extended it over time. However, this set in motion issuance of various standard operating procedures and laws such as the Public Health Control COVID-19 rules of 2020 that had restrictions on movement, closure of borders, imposition of the curfew, closure of schools and other public places. There was also the prohibition of use of private and public vehicles, and other requirements were set up to seek special permission from the resident district commissioners for emergency travel, and this included permission for pregnant women to travel to hospitals. So the government did not take into account the special needs of women and girls and their heightened vulnerability to inequalities while formulating the COVID-19 regulations and the standard operating procedures. And this, of course, gravely affected their sexual and reproductive health rights. So in order for women and girls to realize their sexual and reproductive rights, they need to be able to access accurate information, safe, effective, and affordable and acceptable contraception methods of their choice. They must be informed and empowered to protect themselves from sexually transmitted diseases, and they must decide to have children, and the number of children they choose also matters a lot in realizing their sexual and reproductive health rights. So the non-prioritization of women's sexual and reproductive health needs and the insufficient safeguards to protect these rights during the coronavirus pandemic means that women and girls are prone to unintended pregnancies, which exposes them to unsafe abortions and also has exposed them to other sexually transmitted diseases and HIV, disabilities, and have even led to maternal deaths. We've also seen a rise in teenage pregnancies during the lockdown, and this situation has been worsened by the inaccessibility of sexual reproductive health information, a lack of sex education, and even closure of schools because these youths would be kept busy in schools. But now they are forced to stay with the perpetrators of sexual and gender-based violence. We have seen that, we saw that during the first 2 weeks of the lockdown, where there was a strict lockdown, we witnessed interruptions in regular provision of sexual reproductive health services, such as antenatal services, pre and postnatal checks, and even access to contraception and family planning services. We saw that girls and women lacked emergency pills, especially those that were victims of sexual and gender-based violence. The delays that were associated with seeking permission from the resident district commissioners for emergency travel meant that accessing hospitals was very difficult. And of course, many women died during this time because they had to walk very long distances, especially those that were in need of emergency obstetric services. We saw a rise in a number of sexual and gender-based violence cases. Over 3,000 women and 200 children were victims of sexual and gender-based violence just between March 30th and the 28th of April 2020. And of course, most of the cases went unreported. So many of the victims of sexual and gender-based violence, because of the restrictions on movement, were also not able to access psychosocial support. As I had earlier stated, that during the first weeks of the lockdown, we witnessed interruptions in the regular provision of sexual reproductive health services, such as antenatal services, pre- and postnatal checks, safe and legal abortions, but also emergency pills for victims of sexual and gender-based violence. We saw that the delays that were associated with seeking permission from the resident district commissioners for emergency travel, including to access hospitals, led to avoidable maternal deaths because there were several women that had to walk long distances just to access hospitals. We also saw a rise in domestic violence and other forms of gender-based violence. Several pregnant women were brutalized by the local defense unit operatives that tried to enforce the COVID-19 restrictions of the curfew and the restriction of movement. Although these restrictions have been relaxed, we see that the situation is coming back to normalcy, but schools still remain closed. And this means that more girls are still exposed to sexual and gender-based violence. There's still a high rise in teenage pregnancy, and many of the families have fallen into poverty, which means that many of them are not able to access sexual reproductive health services, which has become an essential service. We see during that time, because legal services were at the time not also declared to be essential services within the first 2 weeks of the lockdown, many of these women and girls that needed services of lawyers were unable to access lawyers easily. They were unable to access the police or even the courts that were not fully functional at the time. So the redress mechanisms for the victims of sexual and gender-based violence were really not able to protect women fully during the pandemic. We saw that there was heightened stigma and discrimination that was associated with COVID-19 and its effects. We saw that there were news reports of pregnant women that died in hospitals because some of the medical workers were scared on operating them or treating them because they were suspected to be COVID-19 patients. So in the process, many of these women lost their lives and with their unborn children. Although the Constitution of Uganda is very specific and intentional in promoting reproductive health rights of women and non-discrimination, we saw that the government did not take into account some of the special needs of women and their heightened vulnerability to inequalities while formulating the regulations.
Now we'll go back to Dr. Ibrahim. Okay, so the Zimbabwe High Court ordered the government to ensure the provision of PPE to all healthcare workers serving at public health facilities as well as to those deployed on field to trace contacts made by individuals tested positive for COVID-19. Earlier this month, we saw nurses being arrested by authorities in Zimbabwe during a demonstration where they were asking for better wages, yet we know the country is facing economic crisis. How best can health workers in Africa bring their governments to accountability?
Thank you very much. I'm coming back once again. I think that there is need for a holistic approach to holding government to account to provide protection, good working conditions for health care workers. The particular case in Zimbabwe, the Doctors for Human Rights in Zimbabwe approached the Harare High Court asking the government to provide testing services, provide personal protective equipment, and train healthcare workers in the fight against COVID-19. The High Court, the Harare High Court, passed a judgment asking the government to provide those PPEs and provide adequate protection for healthcare workers. However, weeks pass, the government has not really implemented or is not seen to have done adequate in protecting health workers or implementing those measures the court put in place. So a holistic approach is therefore needed to ensure that healthcare workers do not only win in the courts, but they also win at the level of the society, at the level of the government. There's social accountability, there's judicial accountability. In the holistic approach, we should see the involvement of civil society organizations. In other healthcare rights advocacies, we've seen how civil society organizations have been pivotal in leading strategic litigations for the realization of healthcare rights. So these civil society organizations can really work hand in hand with healthcare workers through their unions and national associations to see how they can improve on research and documentation for strategic litigation. In strategic litigation, you do not only win in the court on that particular case, you win for the whole community. You win for the next health worker, not the particular case that was brought before the court. So civil society organizations can really have a great role to play in bringing strategic litigation to the realization of the protection and adequate working conditions for healthcare workers. Another important tool is the strengthening of national human rights commissions. National human rights commissions serve as a watchdog and accountability partners for the government in their respective countries. So if we strengthen them, rather than some people see national human rights commissions in countries, even though they are independent, some people see them as just an organization that can really bite hard on the government. So when we strengthen them beyond making adequate legal provisions to ensure that these national human rights commissions can really hold the government to account and tell them that, look, the government, you have not provided adequate PPE for these health workers. The wages you are giving these health workers is inadequate at this particular point in time. You need to improve upon that. You need to motivate the health workers, because a motivated health worker would be a resilient health worker and will be an effective health worker. It will be very catastrophic and terrible when a healthcare worker is being sent out because he cannot pay rent, or is being, or his children are being sent out of school, or he's thinking of the next meal. That health worker would not be effective. That health worker may not be in the right status of mind to really take care of clients with illnesses. So we must understand that the government and the society should understand that healthcare workers need to be adequately taken care of. A healthcare worker should not be asked to be paid his wages, as we see in countries, just like you mentioned, nurses protesting for their own wages, whereas the international labor regulations are clear that workers should be adequately compensated and even motivated. Not just compensation for like compensation, but even motivation. So here is a country that is not giving these health workers their compensation for working. not to even talk of motivation for them to work during this pandemic, realizing that this pandemic is a serious crisis that everyone is trying to understand and really get on with. So I believe a holistic approach that involves civil society organizations, leading strategic litigation, strengthening the capacities of national human rights commissions, and then litigations through the courts, just like the precedents in Zimbabwe, where the doctors approach the court. I should see other countries approaching the courts too, strategically, not just when there is a problem, to tell them that, look, you need to do more, you failed. A healthcare worker should not go down in the line of duty. Putting out the statistics out there before the court and asking the court to pronounce judgment to compel the state to live up to its responsibility. We've seen how strategic litigation has worked in other aspects of health rights, like sexual and reproductive rights. Understanding that some people argue that socioeconomic rights are not justiciable, but we've seen how strategically litigants have been able to approach the courts and gotten favorable judgments that have seen some improvement in health rights. Likewise, those rights of healthcare workers, which has always been in the background, should now come to the fore, because unlike ever before, this pandemic has really opened up the shortfall of healthcare workers and the vulnerability of healthcare workers. Healthcare workers are seen as elites in the community, but we have seen how vulnerable they are currently in the society. We've seen how healthcare workers have have succumbed to the disease, have succumbed to burnout, and are seeking for help. So we should understand that no matter how a particular group of individuals are seen as probably an elite section of the society, they also need help. And it should be a holistic approach to really hold the government to account. Thank you.
Thank you, Dr. Ibrahim, for that. And the right to health, as we know, is a fundamental right under international human rights law. It's also a critical component of the UN Sustainable Development Goals, SDGs, and is recognized in at least 115 constitutions across the world, including the 55 AU member states. Dr. Ibrahim has just mentioned the need to strengthen national human rights commission. And also I'm seeing a question from Elizabeth Ouma, who is asking, has the AU initiative to help members procure products been successful? So I'll hand over to Dr. Amanda to tell us what is the role of human rights institutions like the African Commission on People and Human Rights, and how best can national governments work with such institutions to ensure that they realize their obligations under the African Charter.
You know, with respect to the African Commission, of course, its mandate is provided for in Article 45 of the Charter, and which provides that the Commission should protect human rights and promote human rights, and as well as interpret the human rights that are provided for in the African Charter. So, of course, it has already been doing that. However, in order for there to be more effectiveness for what's happening currently, we need to see the African Charter muscle up on monitoring mechanisms. We need to have the Charter promote more efforts, to push or rather encourage state parties, African state parties, to implement their mechanisms, their commitments to the African Charter towards the right to health. So monitoring there needs to be muscled up by the Charter, as well as setting standards and benchmarks to fast track the realization of the right to health, especially in this emergency COVID-19 situation. We need to see the African Commission coming out more actively to set up the benchmarks. It's also necessary, I believe, from an African perspective, to have the Commission lead the African continent in information dissemination I believe that it's not enough for us to hear from the World Health Organization alone. I believe we should have an African response which will help us contextualize the African situation. So, of course, we have the World Health Organization taking the lead, but if the Commission, the African Commission, then translates and adapts some of those measures to suit the African context and the challenges that we are faced with, it will help in helping our governments take action that is relevant to the people in Africa. We should also see the African Commission, I believe, scrutinizing some of the initiatives of and information of the World Health Organization, as well as supporting some of the responses to the COVID-19 that our African states have been proposing. Of course, sometimes some could argue that some of the responses may not be good enough, but I believe we need an African position to the responses. We had efforts by Madagascar with respect to finding a cure. We have efforts within the region towards working towards vaccines. And these are the things that I believe that the African Commission should be spearheading. Resource mobilization is also something that I noted that must be spearheaded by the African Commission. As to the success of the, sorry, let me just respond to that chat very specifically. As to the success of the procurement of health products, one cannot say yet, because there's something that it's ongoing. One cannot say that it's already successful, not successful. Measuring it now, I would say, would be perhaps relatively premature, but having something in place already, for me, speaks volumes towards actions that are Afrocentric, and which I think is good. We also need some more task forces. I believe we should have the African Commission set up task forces to address some of the issues that are rising. For instance, what Dr. Ibrahim was raising about healthcare workers coming to the fore over issues about defining who the frontline health worker is, etc., etc. These are we also need an African command center to address COVID-19. So for me, these are the issues that will help the African Commission become proactive in responding to Article 45 of the African Charter, as well as to address Article 16 of the African Charter's right to health, to protect, promote. Yeah. For now, I believe these are the interventions that I would want to see from the African Commission. Thank you.
Thank you for that, Dr. Amanda. Moving on to Ms. Speciosa. As an advocate, what is the role of litigation in ensuring that sexual reproductive health rights of women and girls are protected?
First of all, litigation is increasingly being used as a tool of promoting human rights, including sexual and reproductive health rights. There's been a lot of jurisprudence all over the world. Here in Uganda, we borrowed jurisprudence from South Africa on litigating the right to health. As Dr. Ibrahim rightly said, that strategic litigation is a way to go in promoting human rights. So we say that in Uganda, we've been able to hold our government accountable and also hold individuals accountable for violation of sexual and reproductive health rights. We've seen a number of cases that have been filed by civil society organizations and individuals relating to maternal health, sexuality education, and even cases challenging inadequate laws on termination of pregnancy. So litigation is important in creating systemic change and in giving direction for the enactment of laws and policies for the protection of sexual and reproductive health rights of women and girls. We also note that litigation is important for changing attitudes, especially about the stereotyped roles of women and also the moralization of sexual and reproductive health. Because women in Uganda and world over face discrimination based on their gender, and also discrimination and inequalities based on their role as their role of reproduction, but also their status of their maternal status. So changing attitudes of how to treat women and giving women special attention in certain instances is also important in helping women realize their sexual and reproductive health rights. And this has been achieved through strategic litigation and even litigation for individuals. We've also seen that it's been important for raising awareness within the communities, because when the judiciary holds the rest of the government and other people accountable for sexual and reproductive health rights, people in the communities are aware of the rights of women and how they should respect these rights. However, litigation cannot be effective unless there are other ways of advocating for, of putting forward the cases into the communities, especially through social media campaigns, through radio or televised talk shows, or even through conferences. This also enables to raise awareness around sexual and reproductive health and rights. Also, creating increased participation of civil society organizations and women's groups to empower women and girls is also important in also advancing the rights of women and girls aside from litigation. So litigation must go hand in hand with other advocacy methods for promoting sexual and reproductive health rights.
Thank you, Ms. Preciosa. So I'll go back to Dr. Amanda. You talked about the percentages that have been, the percentages that the national budget allocates to health. And we know, we have seen that government's lack of investment in the health sector has been manifested in Africa. In 2001, as you've stated, African leaders signed the Abuja Declaration, voluntarily pledging to allocate 15% of each country's national budget to health. In 2013, only 3 countries had attained the percentage pledged: Botswana 17%, Rwanda 20%, and Zambia 16%. Why do you think governments find it so hard to allocate this required percentage to funds to health, when we have seen the same governments allocating a lot of funds in purchasing military equipment, allocation to youth services, etc.?
Thank you, Cindy. You know, it's I would say it has much to do with political will and government prioritization, especially in our region, over issues that have to do with securing power, the power of ruling parties, etc., etc. Well, this is quite it can be a bold assertion or accusation, but I believe it's just lack of prioritization. And then also, I would like to say perhaps it's also a kind of retrogression towards the right to health, because from the time of independence of most of our continent's countries, there was a lot of effort towards improving the health sector, and therefore you would see work towards budgeting for the health sector. But over the last decade, you see a regression by most governments, focusing more on other issues. And like I've said, you know, when you look at our governments have come from colonization from the 80s, 90s into the 2000s. Now there's that kind of need to enforce or to promote ruling party agendas rather than focusing on the real issues on the ground. So it's mostly about focusing on political matters, political issues. I can say in Zimbabwe, this is quite true. And therefore, the focus then just shifts from very serious basic human right needs, such as the right to health. So it's just priority, Cindy, I believe it's priority of our governments moving away from the need to promote human rights towards a whole totally different agenda of political, addressing political economic issues, I would say. Thank you.
As to our first poll question, which we shall be asking, do you think, the first poll question is, is the 15% allocation sufficient or should it be increased? So 1 minute for that. And then maybe Dr. Ibrahim, you can tell us how can the health sector take advantage to ensure that the health budget is expanded?
Thank you very much. Previously, we understand that from researches from the World Bank and other international organizations, we thought that fee for service was indeed helpful to augment government in taking care of the health needs of the population. But subsequently, in recent years, we come to the realization that fee for service is actually prohibitive still to many people within the community. You can understand that there is this concept of catastrophic health expenditure when people spend up to 10% of their annual income on a particular health need. It sends them into abject poverty. That is catastrophic health expenditure. So some people cannot really afford those fee for service, which were advocated in the past, that it helps the government to recoup the financial cost. So government should understand that health services are social services that should be gotten by all, regardless of the capacity to pay. The Agenda 2063, the blueprint for the African Union, recognizes that at this moment in time, African countries have that reasonable financial resources, reasonable financial resources in collaboration with donor partners to be able to provide social protection to the community, including healthcare services. So I believe that health services should be, as a social protection, should be a sole responsibility of the government, and people should access healthcare services regardless of their capacity to pay at that point in time. The usual debate about socioeconomic rights is that they are not justiciable, and socioeconomic rights are always debated in when the government has, the government should implement them within reasonable available resources. So we can see that the African government is now saying that, yes, we've committed that within this Agenda 2062, we understand that there is that reasonable available resources. So politicians should desist from saying that there is no available resources. The Africa as a community has agreed that there is that reasonable resources in collaboration with donor partners to really fund social protection, including health. This was the one of the agreement at the Livingstone Call to Action of 2006, which agreed that social protection is a basic human right. Social protection includes health right, and social protection is the government can afford to provide the people with social protection, including access to health across their life cycle. Thank you.
Thank you very much. We are now going to close our polls. And I can see that 23% of you say the 15% allocation is sufficient, and 77% of you think that it should be increased. So we'll move on to the next question. we heard from Dr. Ibrahim saying that the mental health cases affecting both healthcare workers and the population during this COVID-19 pandemic has increased. Recently, the president of Uganda said that the healthcare workers have not even been going home during this time. So, Ms. Preciosa, is there need to have a review of public health laws, or what policy frameworks can be put in place to address the current situation and also remain relevant post-COVID-19?
Thank you, Cindy. Yes, of course, there's been serious need for a review of policies and laws on mental health, especially relating to COVID-19 and the pandemic and the experiences of frontline health workers, but also the community and people that have gotten infected with the coronavirus. So I believe that it is important that public health laws and policies should be reviewed to protect health workers who treat patients at a high risk of contracting the coronavirus, especially adults with serious mental illnesses, or those that are caring for minors. There are several laws and policies that have not been updated for a very long time, policies and laws that relate to mental health. We have particularly the Mental Health Treatment Act that is obsolete, and other laws such as the Uganda's Narcotic Drug and Psychotropic Substances Control Act, which treats the use of drugs and injections as which treats people that use drugs and injections as criminals, and this limits the medical interventions that are available and accessible to these people. Since we've seen a rise of depression and issues related to mental health, it's important that these laws are put into perspective. These laws are able to protect both the community and the health workers, but are also able to be used at a future date, and also realize the current situation of the coronavirus and also mental health accordingly.
Okay, thank you for that. We're now receiving questions, so if you have any questions, kindly just post them on our chat. We shall be able to see them and respond to them. So some questions that had been received prior to this webinar is Rose from the Ministry of Water and Sanitation states that there are challenges relating to lack of access to quality and adequate water, hence negating the requirement of Constitution on human right to water. So she would like to have a discussion on this. So Dr. Amanda, would you say something about this?
Yes, thank you, Cindy. The right to water itself is very intricately linked to the right to health. And yes, it's true what our participant is saying, that, once the right to water cannot be provided for, once there's a problem with access to water and sanitation, this negates the right to water itself, because the right to water itself is indeed provided for in international instruments, is provided for in the Constitution, and I'm assuming it must be the South African Constitution that she is referring to here. So the right itself also has the requirements such as those for the right to health, where we need to look at whether it's accessible, whether it's available, with the quality of the water, as well as whether it's acceptable, the water that is being provided for. So in South Africa, as well as in Zimbabwe, I do know that we have water scarcity issues. Governments are grappling with providing for water for citizens, notwithstanding the constitutional provisions that are in place to respect and promote the right to water in both these constitutions, as well as legislation. There is the Water Services Act in South Africa, there is the Water Act in Zimbabwe. But the water scarcity issue is really a challenge for both governments, as I would imagine in other sub-Saharan African countries. So the majority of citizens in both countries do not have water readily accessible. The government has been struggling to the majority adequate water to citizens, and governments have been struggling in both jurisdictions, and also the quality of the water once it's provided for sometimes is not up to standard. So effectively, what this then means is that if people cannot access water, then the right to water itself is compromised, is negated, yes, as well as the right to health. And in the context of the COVID-19 situation or emergency, then it means that it leaves a lot of people, the majority of our citizens, exposed to very dangerous situations, because then it means most of these people cannot have hand sanitizers that from shops. They rely and depend much on the availability of clean and potable water. And when that is not available readily, and then it's really a very difficult and precarious situation that we are faced with. So yes, indeed, there is just the danger of having our governments negating their efforts towards the fulfillment of the right to water as well as the right to health in this very situation. Thank you.
Thank you for that, Dr. Amanda. I'll move over to Dr. Ibrahim, and I'll ask you to answer these two questions. Has COVID-19 pushed other ailments to the periphery in hospitals, that all medics have switched to diagnosing patients attending hospital of COVID-19 at the expense of other ailments? And the second question is, how is Africa as a continent positioned itself in terms of finance and policy in the event that a vaccine is developed from Europe and safe for South Africa? Why hasn't Africa as a continent made joint efforts to research on the Madagascar hub effectiveness instead of jointly castigating it without us before reaching on it?
Thank you very much. For the first question, I would answer it this way. It's not necessarily that COVID-19 has pushed other diseases to the periphery. What is actually happening is that that you are seeing the surge of other diseases is the impact of the COVID-19 as a pandemic and other diseases, just like we've seen in other outbreaks like the Ebola outbreak in West Africa. So with the advent of the COVID-19 pandemic, there were re-regularization into the new normal, even within hospital settings. Routine clinics had to be suspended, or clients are given long-term appointments, whereas their appointments should have been a short-term appointment. And then routine procedures like elective surgeries, elective procedures were put on hold, just like it happens the world over. So putting on hold routine clinics means that a client who walks into the clinic monthly or bi-monthly to do a blood pressure check or a blood glucose check to have a refill of medications would have to stay longer or would not be able to access healthcare services. So in such event, such individuals may come down with complications of their diseases that have been hitherto prevented. So how could we have achieved a better outcome as sub-Saharan Africa? Telemedicine could have been the tool we would have employed, but how many people within the communities have access to digital devices, have access to telephones that you can be able to reach them out as the clinician to ask after their health, do a telephone consultation and be able to offer prescription over the telephone so that they can be able to access it. So these are the limitations that happened over the period, the last 3 months, that saw disruption in the health services. Another issue could be in terms of training and retraining of healthcare workers. This COVID-19 pandemic is evolving. New knowledge is coming by the day. The World Health Organization, the leader in this pandemic, is reviewing guidelines and regulations every now and then, which means healthcare workers that at that point in time do not receive the new regulations, probably it passes 1-2 weeks, may find it difficult to really pick up what is latest in terms of knowledge in the care of COVID-19, and being able to really triage and categorize other respiratory diseases as such. I hope that satisfies. Then the second question, which is a bit long, about the African Union or Africa as a whole coming together to give a unified leadership in this COVID-19 pandemic. I understand that there is the African Union COVID-19 response fund, which aims to raise resources to strengthen the continental response to COVID-19. So I believe if this resource envelope is filled up, it will go a long way in funding research into the COVID-19 as a clinical entity and as a disease, as a vaccine preventable disease, so that Africa too can compete with the international community in putting out a vaccine, not only waiting to receive vaccine trial and also the vaccines, but we can also put up researches to be able to contain the pandemic and join the international community in fighting COVID-19. There are some countries that are putting in effort into research, both clinical and laboratory research in this pandemic. The National Health Research Institute in Nigeria has also gone into research in that regard. I'm aware that they were able to typify the COVID-19 strain that came into Nigeria, and then this is a step in furthering research that can help into provision of vaccine and can help into understanding the clinical entity and the disease cause. The issue of Madagascar hub, well, it is a tradition in the health community to, at the first instance of should I say, a wonder drug or an extraordinary cure to a problem, the medical community or the health community is hesitant to really wade in to such claims until there is scientifically proven research to show that such medications or such concoctions can actually work. So I think it is not out of the ordinary that some countries showed not, I would not call it a reservation, because the Nigerian government, for instance, the presidential task force on COVID-19 pandemic was clear about the Madagascar hub when it came into Nigeria. When it was given to Nigeria, the government said it will go through the National Food and Drug Administration and Control Agency, where the hub will be put to test. It will be put at par with other scientifically proven content, and see its efficacy, whether it is useful and it has passed the minimum standard to be used, to be allowed for mass consumption within the country. So I believe, just like the commentator said, there should have been a communication from the Madagascar government to the African Union as the leader of the continent, the African Union, the human rights organization of the continent, to give a leadership on this hub, to bring in researchers from countries as independent researchers to look at it and advise the continent further, because definitely Africa needs to look inwards. We have the talent. Nobody can say categorically that complementary and alternative medicine are not working. They are working. Other countries in Asia, in Europe, they also have their own complementary and alternative medicine, which they put into use. So we need to just come as an African Union to put up research and support such initiatives by African countries, because if we relegate it to the background, it may weaken the morale of other other countries within the continents to really come out bold to say we have something that is complementary and alternative that can actually help in the fight against this pandemic. If the world over, we are all learning about this pandemic and how to tackle COVID-19. Vaccine is just coming into light most recently, and drugs, there's no universally accepted drug as a cure to COVID-19 at the moment. Clinical trials are ongoing. So alternative, medicines like the Madagascar hub should also be tested, and other countries that also have similar formulations should come up through the standard procedure of testing such formulations, so that we can have a homegrown continental approach to the whole issue. Thank you.
Thank you, Dr. Ibrahim. So now we'll go to our second poll question, which is, do you think that hopefully after the COVID-19 pandemic, African governments will see the need to prioritize investment in the health sector? Do you think that hopefully after the COVID-19 pandemic, African governments will see the need to prioritize investment in the health sector? And as you're voting, I'll hand over to my colleague Peter, who wants to discuss on the issue of prioritization of needs with regards to budgetary allocation and political will. Peter?
Thank you, Cindy. Thank you for that. I think I just wanted to share something, even as we discussed the whole question of privatization. Making health rights and social economic rights a priority for most African countries. And I want to address it from what I consider to be an attitude issue from the African leadership. I wanted to share something with you that speaks to the attitude that the African political leadership has insofar as advancing social economic rights on the continent is concerned. And for as long as we have this kind of an attitude, then it becomes relatively difficult for even talk about concerted efforts at an AU level to promote and advance social economic rights on the continent. Unfortunately, technology is failing me on that. So if I manage to get, then I will share with you. But for now, that is just a comment that I wanted to throw in, and therefore challenge all of us. What is it that we can do to ensure that our political leadership actually makes social economic rights a priority vis-a-vis the other rights? Because the whole question of lack of funds, I don't think can stand. We have seen that even the limited resources that we have, it's all about the question of allocation. countries and governments have always allocated funds even far beyond what they can raise on certain things that they think are priority. We have seen elections in countries, consuming up to billions of shillings for just holding an election. And if they want to do that, they can do it. We've seen funds being allocated to military issues, whether there are issues within the country or outside the country, but we've seen huge budgets being allocated to military. We've seen budgets being allocated to things to do with hospitality within the offices of the presidency or parliament. And then all these things then tell me that the question is not because we don't have enough resources. The problem is where we put those resources. And even during this COVID-19, there are reports from several jurisdictions on the continent where the funds that have been allocated to fight this pandemic, whether generated locally or received as loans and grants, these funds are still being misappropriated. So what is it that we can do to ensure that we use the little resources that we have to do the right things for the people on the continent? Thank you.
Thank you, Peter, for that. And now we are going to end our poll. As you can see that most of us are optimistic that hopefully after COVID-19, our governments will see the need to prioritize investment in the health sector. Dr. Amanda, would you like to comment on that?
I cannot say I'm as optimistic myself because I can already see the response to COVID within our own government and how matters have been dealt with. That I really wonder whether enough is going to be dedicated to health responses. But most certainly yes, there will be a shift in the manner that government begins to focus on human rights, especially rights such as the right to health. There is indeed going to be that shift. But with budget, I cannot say yet. I'm not very optimistic myself. Perhaps beyond our borders, I do believe that there is light there. For instance, South Africa, I have seen the efforts, there's significant efforts being done. If you look at the responses by provinces themselves towards COVID, if you look at how the government has partnered with private actors in addressing COVID-19, if you look at the efforts that they made in hospital, boosting up equipment in hospitals, the efforts that was made in infrastructural development to meet this COVID response. Yes, governments such as South Africa, I think they are already rechanneling themselves to budget even more for health. But I cannot say that for other jurisdictions such as ours, and even and now I'm being very loosely also referring to our neighboring countries such as Mozambique. I cannot vouch for that yet.
I think I am optimistic considering what the African countries have gone through, the burden on the health sector, and the secondary burden on other rights, other human rights, like the sexual, reproductive, and health rights, the mental health rights. So I believe that the government of Africa will be able to prioritize investment in the health sector after the pandemic. So this is just a warning to the African governments to take serious consideration of the right to health, but also to strengthen the public health and public health systems, so that the general burden on the healthcare systems at a future date is not so great. But it's only a hope. We hope that the government will take this seriously. Yeah.
Thank you. Finally, Dr. Ibrahim, what do you think?
Thank you. I think COVID-19 is a game changer. It has brought in uncertainties that even the governments are not sure. Can we survive the next elections? Do we have the funds? Because other economic aspects have been put on hold because of the pandemic. So I believe as a game changer, COVID-19 will conscientize the governments of Africa to really look at their commitments in the past, just like the 2001 Abuja Declaration on at least 15% health expenditure, to see the need to really expand the resource envelope for health. And in all the declarations, you would understand that the percentage is given as at the list. So it should go beyond percentage-wise. The countries in Africa should look at what are their current revenue stand and see what percentage would come should go to health, which should not go below 15% of their national health budget. I can give you an instance in Nigeria, because a great percentage of our revenue comes from oil. So during this pandemic, there was a fall in oil prices globally, which depleted our consolidated revenue fund. And then our National Health Act says the government should give at least 1% of the consolidated revenue fund to fund basic health care. So analysts were now telling the government, look, the National Health Act says at least 1%. And today, because of the depletion in oil revenue, 1% will mean nothing. When you look at the revenue, then you have to go above 1%. So African countries should look beyond the percentage-wise and give commensurate revenue. That percentage is hard to really tell why the African heads of government thought of 15% of the health budget in 2001, but I can understand that 15% of budget might come in a lot of figures, so that may be the reason. So the countries should look beyond percentages and give commensurate funding to healthcare. And I believe COVID-19 is a game changer, and I am optimistic that beyond COVID, we would have a departure from the attitude of African states of not funding health adequately.
Thank you. Thank you very much, Dr. Ibrahim. And as all good things must come to an end, this online seminar is not an exception. On behalf of Konrad Adenauer Foundation, Rule of Law Program for Sub-Saharan Africa, I wish to thank all of you for attending, for your contribution, and for your questions during this session. Special thanks to our panelists, Ms. Preciosa, Dr. Amanda, Dr. Ibrahim. We have been enlightened by your knowledge through your contributions. Last but not least, I want to thank Lawyers Hub, and specifically Victor and Ken, for providing us with this platform and for your support and coordination throughout. I wish you all a good afternoon. Thank you.